Welcome, everyone. We are going to get started. It's right at 2 o'clock, and I'm here to introduce my colleague, May Kwong. May is the Center for Connected Health Policy Executive Director and a good friend of mine and a fellow Telehealth Resource Center at the national level. And May is going to share with us basically an overview of what has gone on with the telehealth policy landscape since COVID. And this is part of a three-part series. So May will be coming back to us during the summit to talk about kind of the future of policy and what we're seeing happening as well as predicting to potentially happen after the pandemic is over and the end of the public health emergency. And then the third part will be our state meetings, where we'll look at a deeper dive at our individual state Medicaid and private payer policies. So without further ado, I am going to flip over to May Kwong.
Thank you, Kathy, and thank you for having me here today. As Kathy said, I'm May Kwong. I'm the Executive Director at the Center for Connected Health Policy, which is the federally designated National Telehealth Policy Research Center. And we'll just get my slides up and running. Lisa, why don't we go to the next slide? And the next slide. So I always have to start off with disclaimers for my talk. So any information that I provide today should not be considered legal advice. It's strictly for informational purposes. CCHP always recommends that you consult with legal counsel if you're interested in a formal legal opinion. And if I happen to mention a company or show a picture of a product or talk about a product, know that neither I nor CCHP has any type of relationship, financial arrangement, or affiliation with such a company. Next slide. A little bit of background about CCHP. We were actually established as a California telehealth organization back in 2009. We're a program underneath the Public Health Institute, but an opportunity to become the federally designated National Telehealth Policy Research Center became available in 2012 through a grant from HRSA. CCHP applied for that, and we've been serving in that capacity ever since we got it then. We also work with a variety of other funders and partners on the state and federal level on different telehealth or connected health projects. And we act as an administrator for the National Consortium of Telehealth Research Centers. Now, for those who are not familiar with the National Consortium, it is made up of the 14 telehealth resource centers that are underneath the same program as CCHP and Matrix. There are 12 regional resource centers, and I'm sure you're all very familiar with the Mid-Atlantic, which Kathy represents. But there are 11 other regional resource centers that cover the other states as well. So if you're from one of those states that is not in the Mid-Atlantic region, I encourage you to reach out to your regional TRC. And then there are 2 national centers, one on technology and one on policy, and CCHP is the policy one. So a couple of years ago, the 14 TRCs, in order to work more efficiently and effectively with our limited resources, we decided to come together and work collaboratively on joint projects. So we pulled together a portion of our funding to do those joint projects, and CCHP was appointed to be the administrator of those funds and also to help coordinate that. Basically, it really means we act as sort of a point of contact for everybody. So people aren't trying to reach 14 TRCs. They can just go to one place and be able to get in touch with all 14. CCHP also acts as the convener for the California Telehealth Policy Coalition. So this is a coalition in the state of California that CCHP actually started back in 2011 before we became the National Telehealth Policy Resource Center. And it's made up of over 100 statewide groups and individuals who are interested in advancing California telehealth policy. Next slide. So this is your 100,000-foot level overview of what's gone on with telehealth policy, both on the federal and the state level. And this is, as I said, it is very, very high level, broad, basically just focusing in on the issue areas that a lot of the policy has touched on. This is not complete. There are other issues and other items that telehealth policy has impacted during the beginning of COVID or has changed, but these are the general ones and the common ones that really happen on the federal and the state level. And you can see both on those 2 levels, there's some commonalities on what they had to change. And a lot of that is also around reimbursement too. But other policy areas were touched upon as well, such as prescribing, privacy, and licensing. Next slide. So we're going to hit the federal policies first. So next slide. Now, to understand federal policy regarding telehealth, you have to understand the majority of it is actually based in Medicare, and that's around what's covered and what's reimbursed. But you also have to understand that Medicare approaches telehealth in two ways. They have their telehealth policies, and then they have something called communications technology-based services. So their telehealth policies are those policies a lot of people are probably familiar with. Needs to take place in a rural area, needs to be provided by a certain provider, can only take place in certain types of facilities. And those telehealth policies, the majority of them are embedded in federal law, and they are specifically regarded as telehealth. And the way CMS looks at it is it's a replacement for an in-person service. So that telehealth service replaces what would normally have happened in person. Then CMS has another sort of bucket or channel of technology delivered health services that they call communications technology based services. And these use telehealth technologies, but they don't call it telehealth. They don't regard it as telehealth because in CMS's eyes, they're not replacing an in-person service. However, technology has been able to make these services available and effectively provided via technology, but there's not that in-person replacement for it. So for example, a telehealth in-person replacement would be like, I go in and I visit my doctor for a visit. I can do that via telehealth. You have a one-to-one replacement. Communications technology-based services are something like, well, I have hypertension. I'm taking blood pressure readings throughout the day, and I'm transmitting that to my healthcare provider. And then at the end of the week, my healthcare provider does an assessment or looks at all the readings for that week. I'm probably not doing that in person. I'm not going into the clinic and having, my blood pressure taken several times a day. So there's not that one-to-one replacement. So CMS has this other sort of bucket of services that they call communications technology-based services that they will reimburse for and that they use telehealth technologies, but it's not regarded as telehealth. And because it's not regarded as telehealth, it is not held to the same restrictions that the telehealth services are. So those federal statute restrictions, such as must take place in a rural area, can only be provided by, this little short list of providers, does not apply to communications technology-based services. Now, why I'm spending so much time making this distinction is that during COVID, I think that got a little confused for a lot of people because a lot of times when CMS was issuing guidance, while they did separate it out and said like, well, this is the telehealth policies that we're changing temporarily, they would also add a section on communications technology-based services. I don't think it was very clear to some providers, especially, that these are two separate things in Medicare's eye, in CMS's eye. And that's very important to make that distinction because they are treated differently, because communications technology-based services doesn't have those statutory restrictions. CMS can really just adjust the policy how they want. They can say which providers can do it, can utilize it. They can say like what location the patient can be in when those happens, etc. And also those communications technology-based services, even before the pandemic, some of those services were allowed to be provided via audio-only phone as well. So that also caused a bit of confusion when COVID first started. CMS said like some services can be provided via audio-only phone and we'll pay them the same amount. People, when they were billing providers, they got a little confused and they were billing communications technology-based services and then wondering, well, I thought we were supposed to get paid the same if I did it via audio-only phone as I would have had I done it in person. And that's because they were billing the communications technology-based services and it had a different fee schedule, a different amount of what they were reimbursed. So just wanted to make that distinction for folks if they did not realize that, or if maybe they were a little bit confused because the policies were like just coming so rapidly in the beginning of the pandemic that it could have gotten a little bit confused or a little bit fuzzy in the messaging. Okay, next slide. So what were the federal policy changes during COVID? Again, so we went from the 100,000 level foot overview that I did a few minutes ago to now this is probably about your 25,000 foot. So basically, when you look at CMS's federal policy for telehealth, as I said, it's around reimbursement, and reimbursement policy itself can be divided into 4 elements typically: service, location, modality, provider, the what, where, how, and who. So CMS changed, or policy changes occurred for all 4 of these elements. So they made some sort of adjustment in response to the pandemic to all these 4 elements, basically expanding them in some way, such as increasing like the types of service that were covered and increasing the provider list. Now the question is like what's been made permanent, and so far not a lot. But we'll take a step back just to remind folks what were some of those at least major changes that took place on the federal level. Next slide. So these are, as I said, just some of the major changes. There were a lot of changes. I think in total there were probably over 200 policy changes in some way, not all of them having to do reimbursement, but in some way there was like a telehealth policy change connected in some way or another. As I said earlier at the beginning, people will be able to access this PowerPoint. There is an appendix that has a little bit more detail of some of the other changes, but I've just picked out 4 of the major highlights of the CMS changes, which was, the 4 elements that I went over earlier and how telehealth reimbursement is structured. So the first one is like location of the patient. So there was a temporary waiver to like expand where the patient was located. Basically, they can be anywhere. So there was no geographic restriction. There wasn't a site restriction. Really important since a lot of people are sheltering in place at home. So allowing the home to be eligible originating site. What was able to be reimbursed, the services, that also was expanded. So prior to the pandemic, there was probably about 100 services that were on the eligible to be provided via telehealth and CMS will reimburse for it list. They expanded that to about 140. Modality, it was basically just live video prior to the pandemic. Unless you're in Hawaii or Alaska in a telehealth demonstration project, then you can use Storm Forward, but essentially it was live video. So during the pandemic, they expanded and allowed audio-only phone. Type of provider, so on the provider list, again, that was embedded in federal statute. It was a very limited list, about 8 or 9 different types of providers who could provide services via telehealth in Medicare and get reimbursed for it. That list was expanded, at least temporarily, to basically, whatever provider is eligible to provide the services that are on the eligible telehealth services list. And they're working within their scope. So basically, they made expansions everywhere in those 4 elements of reimbursement. Keep in mind, though, there were other things that they did expansions on. Again, you can look at the appendix later on after this presentation if you download it. Next slide. What were a couple of the other things not directly related to reimbursement that they made changes on the federal level? Basically, they relaxed HIPAA. OIG said it will exercise discretion on the HIPAA relaxation. So basically saying we most likely will not ping you or penalize you if you were a little bit more loose with HIPAA because you were trying to stand up a telehealth program during this time. Now, I do want to caution people. They said they will exercise discretion. They didn't necessarily say we would give everybody a free pass. So just be careful there that if you now are in a place and you had taken advantage of those HIPAA relaxations to maybe go back to your program and shore those up to make sure you are in compliance with HIPAA now that the immediate rush to stand up a program is over. So that would just be my non-legal advice, but advice to you to consider that if you haven't already. So the public health emergency, once that was declared, an exception in the Riot Hate Act kicked in for prescribing of controlled substances. For those who are not familiar, the Riot Hate Act basically dictates how you use telehealth to prescribe a controlled substance. All other prescribing is based on what the states tell you, but controlled substances, that's controlled by federal law. It's underneath a section that people call as a shorthand Riot Hate Act, because that was the act that put it into federal law. And in that section, it allows telehealth to be used to prescribe a controlled substance without that telehealth provider having seen that person, the patient in person themselves. Now, those exceptions are really narrow, basically saying it's exceptions such as when the patient's in a DEA licensed facility or when the patient is physically with a DEA licensed provider or something like that. But one of the exceptions is when a public health emergency is declared. So public health emergency was declared, obviously, with COVID, so that exception kicked in. So you're now able to use telehealth to prescribe a controlled substance without having to have that in-person exam with the patient beforehand and without having to fall into one of those other narrow exceptions as well. So that was another thing that changed on the federal level that wasn't connected to reimbursement, but was a significant thing for telehealth. Next slide. Don't try to strain your eyes to read this. I can understand that may be a little bit hard to read, but this is just really more of a visual. Again, if you want, you can access the PowerPoint later on. But this sort of like, again, very sort of summation of like what happened pre-COVID, the changes made in COVID, and the permanent changes so far. And as I said a little bit a while ago, I said there haven't been really a whole lot of permanent changes so far, but we'll go over them in a bit more detail now. Next slide. So there are two ways to make permanent changes on the federal level. You have an administrative way, which is just CMS saying, this is what we're going to do. And then you have a legislative route, which is Congress passing a bill and the president signing it, and then it becomes federal law. So actually something has happened. Things have happened both on the through the administrative channel and the legislative channels within the last couple of months that have made some permanent changes. So we'll go into them a little bit deeper. Next slide. And we'll start first with like the administrative channel. So for CMS, typically to make administrative changes permanent, they'll go through the physician fee schedule process. For those who are not familiar with it, the physician fee schedule is basically CMS every year comes out with a bunch of proposals for the Medicare program for the following year. The proposals come out around the summer of the year before. So last year they came out around August of 2020, and it's their proposal on what they want to make or change for the following year. So there's a period of time where the public gets to like respond and make public comments. Then CMS analyzes it, types up responses to those comments, and then they finalize their proposal for the following year sometime around late November, I think it was early December this last time that they finally, they published their finalized version of it. So, and then it kicks in January 1st of the following year, all those changes that they said are final. So what did they do? Well, of the COVID changes, really, again, CMS does not have a lot of options on what they can do themselves to make permanent. A lot of that is embedded in federal law, so it really does take an act of Congress for that to change. So CMS really kind of has their hands tied for the most part. The one area where they can make administrative changes permanent is around the services that are covered. That is the one element in those 4 elements of reimbursement policy that CMS does have control over. So what they did was they proposed what services were on that temporary COVID service list that they said that they want to put on the permanent telehealth list. So this is the permanent telehealth list, which means when the public health emergency is declared over, services on that list will still stick around. You can still provide those and get paid by Medicare. And what they did was they said that we are going to put these codes on the permanent list. Now, I said that there were 140 on that temporary list that they added to the telehealth eligible list. And this is only about, what is that, 8 or 9 codes, 9 or 10 codes. So not a high percentage. They didn't add a whole lot onto the permanent list. But they did add some, and those are the ones that are, now again, if the public health emergency is declared over tomorrow, these will still stick around. You can still use telehealth to provide them. Next slide. Now, the other thing that CMS did, again, apologies, I realize this is like kind of small font. But again, you can access a copy of the PowerPoint. What they did was they said, there's a lot of other codes on that temporary COVID telehealth eligible services list that we're just not quite sure of. We need a little bit more evidence of it. So what we're going to do is we're going to put them in a bucket called Category 3. Now, when CMS decides what services to put on their permanent telehealth reimbursement list, they have 2 tests in which a service will like go through to see which test that they can pass to get on the permanent test. The first test is called Category 1, which is if the service is very close to a service that is already on the permanent list, it can pass the Category 1 test. The other test is called Category 2, and the Category 2 test is basically, well, if that service can be shown to be done effectively via telehealth and can provide the service effectively via telehealth, and there's evidence of that, it can pass the Category 2 test. Now, the Category 2 test is very hard to pass. Part of the reason is because it's a little bit vague as to like what's enough evidence that it's, you had a study that had 1,000 participants in, it was published in like 15 peer review journal articles, or I mean, what does that mean, like having enough evidence? And it's not quite clear. So a lot of times things usually just like get on the telehealth permanent list because it passed the Category 1 test. So because CMS thought that there were quite a few services on the temporary telehealth COVID list that they were interested in but didn't have enough evidence to have it pass either a Category 1 or a Category 2 test, they said, we're creating Category 3. So what does Category 3 mean? Category 3 means that the services that are in Category 3 will stick around until the end of the year that the public health emergency is declared over. So for example, if the public health emergency is declared over June of 2021, all of the codes on the temporary telehealth service code list will disappear except the ones that have been made permanent or the ones that are in Category 3. Those will stick around temporarily until the end of the year. So if the public health emergency is declared over June of 2021, these codes in Category 3 at least will stick around through December of 2021. And in CMS's eyes, they said that'll give us more time to like gather the evidence to see if it could pass a Category 2 test, or if we realize it's closer to like something that's already on the list, so it could pass a Category 1 test. And these are the codes that they selected to put in that Category 3. A lot more here, but again, they are still in that temporary holding bucket when the public health emergency declared over. So they're not quite on that permanent list yet. They're just a step closer to it. So there are quite a few more lists on here or codes on here as well. So that was the other thing that they did. So next slide. Now, I spent all that time talking about communications technology-based services. So they did make some clarifications around those policies there. As I said, CTBS services, that's a CMS thing. It's not underneath federal law, so they can like craft the policy how they see fit on this. And how they saw fit was to like expand it to allowing other healthcare professionals use them. They clarified some of the other policies. Again, I know that's small font, but this is stuff that you can look at later. So there was like changes around that as well. And that was something, again, that CMS could do because this is their own sort of policy. They didn't have to wait for Congress to like change it, but they did do some clarification. They did expand a little bit to allow other healthcare providers to utilize some of those codes. Next slide. Other changes made, not necessarily related to reimbursement. So as I said earlier, while a lot of the changes made in response to COVID were around reimbursement, there were other policy changes as well that impacted the utilization of telehealth. So some of those things, for example, were like using telehealth to supervise residents, and others were like frequency limits. So an example of that is skilled nursing facilities. Before COVID-19, you could only have one telehealth visit every 30 days for a resident in a skilled nursing facility. During the pandemic, during COVID, they removed that frequency limit and just basically said you can use telehealth however often you want it. For their permanent policy, the change that they made in physician fee schedule is that we're changing it from once every 30 days to once every 14 days. So they increased the frequency limits in which you can use it. So that's an example of some of the other policy changes that they made in the physician fee schedule. But as you can see, not a whole lot, and definitely not the major ones that impacted the use of telehealth in Medicare. That's because, again, that's underneath Congress to do. So let's go and turn and see what was done legislatively. Next slide. So there have been some pieces of legislation passed. So there was the Consolidated Appropriations Act. It was passed in December of 2020. It was right around that Christmas time there. So people may have missed it, or they vaguely heard about it and didn't realize what was in there. So what was in there actually were anything with the temporary changes and done to telehealth policy in response to COVID. There were some telehealth provisions in there, but those temporary policy changes that were enacted to respond to COVID, they did not wind up in here. So the removing of the rural restrictions, allowing FQHCs and RHCs act as assistant site provider did not appear in the Consolidated Appropriations Act. What did appear? So the telehealth provisions where they did expand the eligible originating sites, but they expanded it to critical access hospitals or other rural health facilities with less than 50 beds, and they're calling them rural emergency hospitals. So that was one expansion, permanent expansion that they did. And they also expanded the use of telehealth to provide mental health services, which sounds great in the beginning when you look at the first part of the policy, but then they added a caveat. They said that we're going to expand the use of telehealth to provide mental health services, and we're not going to have the location restrictions. That means the geographic restrictions, the site restrictions apply. However, the telehealth provider must have seen the patient within the 6 months before providing telehealth services, and they must see them in person. That in-person requirement really then narrows down the opportunities, I believe, in like using telehealth to provide services, because you might have the telehealth provider who's using telehealth because they are a great distance from the patient, that it would be very difficult for the patient to see them in person. Requiring now that patient to be seen in person before they can use telehealth to provide services, and within that 6-month window. So even if you saw them, let's say you saw them in person, but it was a year ago, that does not count. It has to be within that 6-month window before the telehealth service is provided. Really narrows down the scope of this. Now, that's only if you're trying to take advantage of like the geographic and the site limitations. So if you're still in like kind of that, I'll call it classic, but the classic model before COVID-19 of where, oh, you went to like a federally qualified health center, they hooked you up with a telehealth provider, and you met all the other requirements, such as you're in a geographical location and so forth, then you don't need that in-person, except that in-person visit there to have taken place. But if you are trying to avoid that geographic and that site limitation, that in-person requirement would kick in. Now, how, the more, how do you record that, all that policies? CMS has not issued any guidance on this yet. This is just, I'm just talking about what wasn't said in the act yet. So how this is going to be administered and implemented, it's still a little bit of a question mark because no guidance has been issued yet. Other things that were in the Consolidated Appropriations Act, so there was $250 million for the COVID telehealth program underneath the FCC. Some of you may remember back in 2020, during the CARES Act, there was $200 million given to the same program. So there was another $250 million given. There was also some broadband money for tribal and also for low-income families, a subsidy given to access more broadband. So that was encouraging to see. But as you can see, again, none of the temporary changes that were implemented at the beginning of COVID appeared in this particular act. Next slide. The Reconciliation Act. So this is the most recent one. Again, none of the temporary changes appeared there. There were some telehealth things in there, mainly funding for grant programs and so forth, but not any incorporation of the temporary policy changes. So here are a couple of things that pulled out there. So $140 million for IHS for, not only just telehealth infrastructure, but for EHRs and information technology, some funding for local behavioral services and grants, and then emergency rural healthcare development grants where telehealth is an element. It's not specific to telehealth. Telehealth is just a part of a bunch of other things. Emergency assistance to family home visiting program. They can make use of virtual visits. And then an interesting thing, funding for family violence and sexual assault victims. Again, the ability to use virtual visits. So not a whole lot of telehealth stuff, and definitely none of the sort of making permanent some of the temporary changes that I think some people were hoping would be made permanent by this point. Next slide. Other federal actions that have taken place. So most of you have probably heard by now the public health emergency looks like it'll be extended through the rest of the year. So people aren't as worried about that cliff effect happening when the PHE was just being, extended literally like a few weeks before it expired. So there was that there. I'm going to talk more about this at a later presentation, but a couple of things to note is that there's probably going to be, a little bit more scrutiny and a little bit more thoughtfulness going forward on what to make permanent for the telehealth policy changes, both on the federal and the state level. We're seeing that kind of on both levels, that there's going to be a little bit more discussion, a little bit more calls for data on what to make permanent. So, but you got to turn in for the March 31st session in order to hear a bit more details about that. So next slide. So just consider that a teaser. State policies, what are going on the state level? So let's go to the next slide. So before COVID hit in the Medicaid program, you basically had every Medicaid program in the United States reimbursing for something via telehealth, usually live video. And a lot of times it was behavioral mental health services, but every Medicaid program was doing something, some of them doing more than others. Storing forward and remote patient monitoring, not as popular. And that's important to note, the remote patient monitoring number, because if a Medicaid program was allowing the home to be an eligible originating site, it was usually because they were reimbursing for some remote patient monitoring. And by having that low number, that told you less than half the states probably allowed the home to be an eligible originating site. So when COVID hit, a lot of states had to change that and, allow the home to be an eligible originating site. Next slide. States also had commercial payer laws regarding telehealth. So the majority of states had some type of law in their books before COVID-19 saying how private health plans were supposed to treat telehealth. And the laws ranged from a state saying, health plan, you can cover telehealth if you wish to, all the way to a state saying, health plan, you shall cover telehealth delivered services the same way you would have in person. And by the way, you will pay the same amount to the provider that you would have had they done it in person. And then all the other states kind of fall in between there. So that really dictated a lot of control, how much control a governor had over health plans and telling them what they had to do in response to COVID. Although to the credit, a lot of health plans just automatically went ahead and did a lot of that without being told by a state governor. They just decided that we're going to do this with telehealth in order to address the pandemic. So that was another sort of factor going on the state level as well. Next slide. So what have we seen? So CCHP last year, between July and August, because that's where a lot of the legislative sessions were ending, did do analysis on what's been made permanent so far. And we found that 31 states had made permanent changes. A lot of them, though, did it through administrative channels. So their Medicaid program decided that they were going to make a policy change, and it didn't necessarily happen through legislation. However, unless it was labeled COVID, we weren't exactly sure if that may have been a change that was in the works. Obviously, if it was labeled COVID, then we knew they were doing something in response to the pandemic. But if they made a policy change and there was nothing related to COVID on there, we weren't quite sure if that was something that they had been considering even before the pandemic. Next slide. So what were some of the changes? A couple of states did adopt policies around audio-only phone and reimbursing for it in their Medicaid program, but they did it in a very narrow way. So they would only say, we're allowing audio-only phone, but only for these services. So it wasn't sort of a widespread, another alternative modality from live video to provide services. They only said for these specific set of services. There was a lot of clarification allowing the home to be an eligible originating site. Again, that was one of the biggest changes that we saw, at least a temporary change, both on the federal and state level. Again, makes a lot of sense. Highly infectious disease, a lot of people sheltering in place at home, had to make the home an eligible originating site. And then clarifications on FQHCs and RHC policies and Medicaid, which had been an issue before COVID-19. It wasn't quite clear on how Medicaid programs were treating FQHCs and RHCs. Could they be distant site providers? Did they, what modalities were they able to use, et cetera, et cetera. So there was clarification by the states to make it a permanent policy to say something like, that they are allowed to be eligible telehealth providers, or, that they will be paying like their full PPS rate. So that was good to like clear up that policies as well, to like have that be a permanent fixture for some of the Medicaid programs. Next slide. So just again, a little bit of a teaser for the March 31st one. So what are some of the trends that we're seeing on the federal level? Reintroductions bills that were introduced last sessions, reintroducing them again. On the state level, these are the trends we've seen so far. We are in the midst of a lot of beginnings, early days of legislative sessions for the states, but these are the things we've clocked in so far as what's been introduced. Payment parity for private providers, allowing telephone to be used in Medicaid, again, very narrowly tailored. And then licensing is also a big issue, as well as requirements for regulatory boards to create regulations around telehealth. Next slide. And these are just a couple of links to CCHP's website. We have been tracking all the COVID changes, both on the state and federal levels. And also you can subscribe to our newsletter if you want to be a part of that as well. We do send out a newsletter once a month, and then every week we send out sort of a topic of the week of either a new report, new study, or like a breaking news of something. Next slide. And that is it. And I think we can open it up for questions. I'm not sure. I think people might be typing them in and not actually verbally asking them.
Yeah, there is a question box. I only see comments, so someone who says they don't have audio, which I hopefully is just your speaker settings. And then someone asking about the slide set and whether it's available now, and it will be added to our virtual event app. I'll probably add it later today, but the video recording will not be available until probably next week.
There's one question there. Will various levels of care be considered for and or a part of virtual service delivery space? I think it already has been. I mean, if you go by CPT codes, the different codes are at various levels of like what codes are allowed to be reimbursed for. It's a little tricky. So it might be a little trickier depending on how the policy is set up. So CMS sets it up with like actual CPT codes. I mean, you can't deviate from the list. Those are the codes. That's it. Medicaid programs can be a little bit trickier. So some Medicaid programs do it by codes, but others just have like a little more blanket policy of like, we'll reimburse for telehealth delivered services if they're covered by our Medicaid program. So that may sometimes cause like a little bit of confusion, because sometimes the codes would not qualify because there may be an in-person element too, but they kind of already do that already. All right. Has there been any guidance about whether alternative modalities like Zoom might be approved long-term for telehealth? So you're talking about platforms. It's not that they've been approved for telehealth. There's not necessarily a approval process of like what technology you can use for Zoom in order to qualify for reimbursement. Your first thing is if it's considered sort of a medical device, then you would need to make sure it passed through FDA. So you would need first check on that. And then if it's not classified as a medical device, but you're using it to facilitate your telehealth interactions, such as like the Zoom platform, you want to make sure it's HIPAA compliant. So it's more about meeting those compliancy standards than there is a list to say, these are things okay to use for telehealth, and then you can get reimbursed if you do that. So there's typically not that type of specific policy with like any sort of payer with Medicare or Medicaid. They just say like, make sure you meet HIPAA compliancy, make sure you do your due diligence and you meet all the other things that you're supposed to do if you provide it in person. What specific bill do you think will be reintroduced and when? Best guess? Oh, a lot of them have been reintroduced if you're talking federal level. So there's the TREAT Act, which deals with licensing. Let's talk of the Connect Act. So the Connect Act was the big one with a lot of the reimbursement changes, and that's been around for a couple of cycles here too. So it gets adjusted every year on depending on what's going on. So that's a big telehealth bill. I don't think that one's been reintroduced yet, because I think they're still tinkering with it, deciding it. But there have been other bills that have been reintroduced that were there from the last session, making some of the temporary changes permanent, such as, allowing FQHCs to be distance site providers, that type of thing. Do you know of anything in the CMS about providers who are under supervision being reimbursed by Medicare? So I think this is asking about that temporary policy allowing telehealth to supervise people. That's still around. So keep in mind, the public health emergency isn't declared over yet. So all of those temporary policies are still around. The question is like, what's going to be made permanent? So we don't have to worry once the public health emergency is declared over that it goes away. So that one is still sticking around. Will it be made permanent? Again, check in on March 31st. Kathy, I'm promoting your March 31st one. So you're going to have to check in on March 31st for that.
Yeah, May is going to be our closing plenary, and we'll be addressing the future of.
What's the anticipation for guidelines related to SNF implementing telehealth? I'm going to assume you're thinking of CMS issuing guidelines. I have not heard that they were going to be issuing guidelines. I would really doubt that they would. Yes, so you are. So I have not heard that they've been working on guidelines on that. I mean, Kathy, have you heard of
I have not heard specifically about SNF guidelines. I mean, they did do some guidance documents around SNFs using telehealth, but I don't know if those are permanent or if there's a move toward any permanent policies.
Yeah, I haven't heard of them or even updating them at any point here. So, or anytime soon. I have not heard them considering that. How about the messaging processes?
Diana Pash had her hand up. Jason, do you want to promote her?
While Jason's doing that, there is another question about how can we best advocate beyond alerting our reps. Quite honestly, talking to your local representatives about telehealth is really important. That's probably the best thing to do, really educating them on that. So I would suggest that you reach out to them, really educate them on the impact that it's had. And if you're a clinician, the impact that it's had on your patients as well. I mean, quite honestly, that is the best route to do. Other things that you can do is maybe find organizations that are local to you. Like I mentioned, in California, we have the California Telehealth Policy Coalition. Maybe there are other organizations in your area that are interested in telehealth policy that you can join forces with to sort of help amplify your voice as well.
And Diana, if you want to go ahead and enable your mic or video, we can hear you. Is she there?
My video's not working well, so.
Your mic works.
That's fine. Mic is working.
Good. Thank you both very much for this. It's been very beneficial as we finish working on state guidelines regulations through the Division of Telehealth here in Kentucky. I have a big project coming up with a SNF, and we've partnered right now. We're just using it as a pilot. I do anticipate or would expect, just from the overall scope of what healthcare looks like now, that there's going to be a push at some point in time for SNFs using telehealth to the betterment of their patients and resource and all this. But I haven't found anything out there or a good resource. So if there is a good resource, I appreciate getting that information. And if not, I'll just keep moving forward like I am with all the other resources I have and with the people that I know.
So West Health Foundation did put out a guide. This was pre-pandemic on using telehealth in a long-term care facility. I can send that link over to Kathy, and she can get it out to folks, post it if they need it.
That'd be great, Kathy.
Yeah, Diana, we actually have a whole set of resources with the West Health Guide in our toolkit. So on the Matrix website, if you go to the COVID toolkit, and if you look at the broad subject area of specialty, like specialty providers and locations. There should be something on there. We are also in the process of developing a best practices document on long-term care, and that should be available probably in the next 2 or 3 weeks.
Great. I would like that information. We're looking at doing this very small and slow and steady, and we want to be able to capture the right data from this study that will be able to be implemented as we move forward with all other SNFs. So we've started small, then we're going to keep growing. I feel very fortunate that we have a provider, we have a hospital, we're implementing an ED, and the numbers will be small. But I do think once it starts, then I want it to have enough rigor and validity to it, and that it can be sustainable so that they can now use this and keep adding it to other places. They don't have a lot of support in SNFs for things like this.
Yeah.
So this is one of the things the division's trying to do, is to help them garner that and then get them all into whatever. I think we have a leading age organization here too. So
And the SNF is a skilled nursing facility, for the person who asked what's a SNF.
50 years ago.
Yeah.
Yeah,
we just
correct me.
All right. Well, thank you, Diana. And just email me if you want more information from our toolkit resources.
I will. Thank you very much, both of you.
All right. With the new administration, do you expect any further movement on making more permanent telehealth changes, maybe by executive order? Stay tuned for March 31st. So, certified recovery specialists are able to deliver support services, my messaging, etc. Would this be something that's being considered to date as a paid platform? So is this a texting platform? I'm not familiar with it, but if it's a texting platform, not in Medicare, some Medicaid programs, and you'll have to check your state, may have allowed texting. Not all of them did. And I can't think of which ones off the top of my head. Medicare, I don't believe did, at least when you're talking about telehealth. Now, when you're talking about those communications technology-based services, there may be a little bit of leeway there. But if you're talking telehealth, no. They just basically allowed audio-only phone or live video. That was the only change that they allowed.
Yeah, with that virtual communication service, I think if you're messaging through your patient portal, that is a reimbursable service.
Yeah, but that would be considered their CTBS. Now, keep in mind, the reason I stress CTBS so much is because that's a different payment schedule too. So you get different amounts for those services, and a lot of people have found out to their chagrin, some of it is a little bit lower than what they were expecting. So just be aware of that. Also talk with state agency controlling prescribing and reimbursement around needs. Ask for them to review use during COVID-19 to look for benefits and concerns and look at actual data. I'm not sure if there's a question in there. I think that was just advice that somebody was giving. CBTS, that's a communication-based technology services. Sorry, acronyms again. So that's like that other bucket of telehealth technology delivered services that CMS has that is they don't consider telehealth, so they have their own policies around it and their own sort of reimbursement for that. Now, also I want to stress though, some states have picked up on that as well. So that might appear sometimes in your Medicaid programs, but some states, and this is why I said it gets confusing, some states have started to treat that as telehealth. So they've included it with their telehealth policies, some of those codes, and then others have like treated it separately, again, like the way Medicare has. So yeah, it is a bit of a mess and a mixture of there. But if you're talking Medicare, they do keep it very separate and distinct.
Right. I am not seeing any more questions or raised hands. If you do have additional questions, pop them in the Q&A or pop your hand up.
Mm-hmm. And while we're waiting, Kathy, you know, what else is coming up next? I'm sorry, I haven't had a chance to look at your agenda.
We do have on Wednesday a session on kind of the nuts and bolts of providing telehealth services. So a deeper dive than the typical 101, which is we're really looking at, you know, how do you do a physical exam, telehealth etiquette, how do you engage the patient, and how do you even explain telehealth to a patient? So stay tuned for that. And we're going to have a really robust panel for that. And it'll be a longer session.
And that's really important just from personal experience. So not all providers are created equal in how they communicate through their patients. So that would be a really good panel to attend if you have any questions regarding that. Please clarify the patient portal messaging that is reimbursable. Is this provider specific? All messages responses. So that's one of those communications technology based services. It's a patient portal, or they may call it e-visit or something like that. They have like various names that people have used interchangeably. That is something where they do allow like a messaging type of service, but it's connected with some type of patient portal, something like that the provider has set up. So you need to look at those communications technology-based services policies and not the telehealth policies if you're talking about Medicare. So this discussion that we're having right now is we're focused in on the Medicare policy.
And the way that you kind of bill for it is by amount of time. So you really have to kind of track how much time you're spending working with the patient. So is it 5 minutes? Is it 10 minutes? And there's a different billing amount for the, different time ranges.
Mm-hmm. And there may be a consent requirement as well that's included. And isn't that defined in the CMS information? They have some guidance on that. So Mary Devaney, another one of the TRCs from Great Plains. So.
Anything else? Okay, well, not seeing any other questions or hand raised. So I just want to say thank you to May for a wealth of information. We will get the slides up in the virtual event platform shortly. Let's see, there's a little chat message coming up. Not sure what that is. But we do invite you back for our other session, our other bonus session, and obviously for the rest of the summit when we actually get rolling on the 28th. Hopefully you are enjoying this platform and would love for you to stick around and just play around with Remo. So we are using Remo for part of our presentations during the session, and using another event platform for part of it. So we wanted Remo to really be able to give you a sense for the networking piece. So if you want to stick around for the next 15, 20 minutes, this room is open and you can kind of network. So go from table to table. If you see other people at a table and you want to join them, just double click on that table. And with that said, I think we are done. So thank you for joining us.
Thank you.